Um, Welcome to the latest webinar organised by the Global Platform, and this webinar is also being co-hosted by the British Society for Population Studies. And I'm extremely grateful to Anne Shepherd and Athena Black-Antoni, who's actually one of our discussants today from the BSVS, who very much helped to organise this session and to publicise it. And so the focus today is demography, and clearly as the pandemic unfolds, demographic analysis has never been more important or more urgent, and also more high profile and in the public domain. And you know, here are some data on reported COVID deaths for South Africa, and you can see the different waves of the pandemic over time. And you know, everybody, not just academics or analysts, but you know, the general public are seeing these sorts of data, you know, on a regular basis, and it's really become a key part of how the public understands and perceives the pandemic. But of course, as we all know, in many cases, these data are extremely flawed and can lead to very problematic interpretation of what's going on. So staying with South Africa and deaths over time, I've added a line here. This is taking into account all deaths over time, so you can see what excess mortality would be. And these data are derived from the South African Medical Research Council, which is actually an official agency in South Africa, and they estimate about 90% of those excess deaths are attributable to coronavirus. And of course, we're seeing this in many countries, that you know, the numbers are being hugely underreported. And clearly, this creates a real challenge. The Global Platform, the network which I helped to operate, has been very vocal and very engaged in the problem, the limitations of data, both in terms of data that were collected historically and systems of data collection which were not up to scratch in many parts of the world, in countries like India, and more specifically the collection of data during the pandemic, which often means, of course, we can say very little about what's going on, particularly as older people are affected in low and middle income countries. And clearly there was a key role for demographers here to try and make the most of what data are available, but also to be realistic and critical about what data are not able to tell us. And so this is a big responsibility for demographers. And because of these problems, clearly demographers also need to find new, unusual, less conventional ways to generate demographic information to help us understand what's going on, such as counting burials and funerals. So here we've got data, which I'm sure a lot of you are now familiar with, looking at the numbers of official COVID deaths in different parts of India and the numbers of cremations for COVID victims specifically, and you can see the vast differential. So I think there's a need for demographers to say, you know, you can't just, you know, rely with a few caveats and a few apologies on official reporting, because the official reporting is so bad. There's a need to be perhaps rather more proactive and bottom up and creative and trying to gather more reliable and more robust information. And so I think this is very much throwing the gauntlet down to demography to do that. And a final quick point before we start the webinar properly is I think we always also have to be mindful that the way data are presented, demographic data, health data, is never neutral. And just as one example, this is a screenshot from World Health Organization website that still refers to all people aged 65 or over as dependent, collectively dependent, and all younger adults as economically productive. And you know, dependency ratios and these sorts of labels, of course, again, people will always use a caveat and say it doesn't mean what it seems to mean, and you know, of course, we realize that this is a big generalization, etc., etc. But we continue to use that terminology, and of course, this has generated a discourse which, in some parts of the world, including in India and the Philippines, has been used to justify sidelining older people from COVID vaccination, saying, well, they're a burden, and we have to focus on people of productive ages. So I think demography has to be much more careful at times about what they would say is a technical presentation, and realizing that because these numbers are much more in the public domain than they used to be, they have to be very, very careful about how those numbers or ways of presenting or describing them may be interpreted or misinterpreted. So there are lots and lots of issues we're going to talk about today, and we've got a fantastic panel to do the job. So I'm going to shut up now, but before the panel begin, I will quickly hand over to my good colleague Lucas, who will explain how questions and answers and things like that will work during the session. So over to you, Lucas.
Thank you, Peter. Welcome to all the attendees. We are gonna be taking questions and comments only on the chat and on the Q&A button, because the YouTube is not working. I'm streaming on Facebook, but I have to find the link and send to all of you.
Thanks, Lucas. And just to add, I'm going to move now to our lineup. We've got four speakers and one discussant today, and each of them is going to speak for about 15 minutes. We won't take questions during or at the end of each individual talk. We'll save up questions for about 20 minutes to half an hour of discussion at the end. So we've got a lot to get through, but if you put your questions into the chat box, we will compile those and we'll make sure that your voice is heard at the end of the session. So without further ado, I'm going to introduce the first of today's speakers, who is Ramon Martinez from the Pan American Health Organization based in Washington. And Ramon has been working very hard on many aspects of the pandemic. In fact, he co-authored a paper in The Lancet on childhood vaccination that came out today. But about 15 months ago, Ramon was leading some work that the Global Platform was involved in, which was seeking to develop a very simple tool to try and project the potential number of deaths from coronavirus and how those would be distributed across different age groups, depending on how many people in each country were infected. A simple proactive tool that could at least provide us with some preliminary predictions about how the pandemic might play out. Very crude, very simple, but something that we could at least start to dialogue with policymakers and advocacy organizations with some kind of evidence to support some of our claims. So it was very influential last year. We kind of left it to one side over the last 12 months. And Ramon and I thought it'd be a very good idea to go back to that and revisit it and see whether what was done is something that was a kind of knee-jerk emergency response to the pandemic, which now perhaps is best forgotten about, or whether there's still something in that experience that we can learn from and apply as the pandemic continues to unfold. So, Ramon, the floor is yours.
Thank you so much, Peter. First, for the invitation to participate in this webinar, and secondly, it's an opportunity for me to be here and present and talk a little bit about this simple tool, as you mentioned, but that is it was very useful at the moment in which was developed. I'm going to start sharing my screen. Let me share my screen. So let me put the presentation mode here. Okay, do you see my screen, right? Okay, great. So again, I'm going to talk a little bit about our effort about a year and a half ago. It was just at the beginning of the pandemic, where the number of cases and deaths were very high in Italy and in China, and we have the need of try to predict in a way what is going to happen in terms of number of deaths in different countries based on some parameters that we we know from the epidemic in specific countries like China and Italy. So again, I'm going to introduce, provide a brief information about the tool that we call the potential impact of COVID-19 in human mortality calculator. It's an interactive tool and very easy to use. And I'm going to provide the information about the data sources and methods and the assumptions of the simple methods that we implemented in this tool. And lately, I'm going to make a kind of tour with the tool to demonstrate, to illustrate how we can use the user or readers can interact with the tool. So let me start saying that this tool is a simple and easy to use tool. Is a web-based tool that is trying to estimate the expected number of deaths in the population in a country or at subnational level based on the observed mortality experience of COVID-19 epidemic in some countries, based on information that we have from specific country. And again, this is important in countries in which we have limited information and we want to estimate or predict what is the number of deaths expected based on the number of population and information from other countries' epidemic. So the tool use basically three parameters: is the size of the population by age, the observed case fatality rate by age in countries in which we have information of the COVID-19 epidemic. And we try to model or use all the different scenarios based on the level of infection in the country. This tool is intended to support some analysis of hypothetical COVID infection scenarios, and again, to estimate the number of deaths by age based on case fatality rates, case fatality rate observed in COVID-19 epidemic in China, Italy, and South Korea for selected level of COVID infection in the population. So the data sources that we use were, again, case fatality rate that were derived from the confirmed cases and death, and obtained from the data reported by China and Italy and South Korea. And we use a population estimate by sex and age and year and location. Location in this case could be a country, the region, or the global level, based on estimate from the world population prospect. And for subnational estimates, we use national census data and a network of researchers and contributors from countries help us to get and build this database. So the method is very simple. We calculate the expected number of deaths by age and country using this simple formula, in which we have here the expected number of deaths by age and country. We have the size of the population by age of country, and the level of infection, and that is a parameter that we change in the tool, and the case fatality rate observed by age, again, in China, in Italy, or South Korea. So it's a very simple method or equation to calculate or estimate the expected number of deaths. in terms of the assumptions, the method used to estimate the expected number of deaths that is assuming that the case fatality rate due to COVID by age in a specific location is similar or like that observed in China, Italy, or South Korea. And the other assumption is that the distribution of case fatality rate by age remains constant in every population group or every country. And the infection rate is the same in every age. That is other element, other assumption. And the final assumption is that the case fatality rate in China, Italy, and Korea is actually the underlying case fatality rate. Again, we actually don't know that those assumptions are true or are robust enough. So that's why we say that the results from this tool need to be interpreted with caution. So, so this is a screenshot of the tool. We developed actually first version of the tool in which we use population estimate from the world population prospect and a different level, a global, sub-regional, and national level. And then we developed other version that is similar, but it was using a population estimate at subnational level. So let me try to show you the tool to do a demonstration. Let me go. I think over here. Okay, so let me refresh this. So this is the tool that estimates the number of deaths at global, regional, and country level. So first, see that we have here at the top, we have a navigation tool here, I mean, a kind of navigation tool at the top. So now we are here in this section, that is the tool itself, I mean, the calculator itself. So the calculator, we have here a selector that allows us to select the country, the region or sub-region that we want to focus our analysis. Let's say that we select here Argentina, for instance. So we need to define or select the case fatality rate from China, Italy, or South Korea, right? So I'm going to start selecting China, and we have here the level of infection that we think or expect is occurring in Argentina. So we have what we have here in this table is by age. We have the population. This is estimate of population, again, based on World Population Prospect from United Nations. We have the case fatality rate observed in China by age, you see. Note that if I change to Italy, then those numbers change, you see. So let me select China. And then we have here three hypothetical, I mean, scenarios. One for 50% in which it is considered that 50% of the population in Argentina is infected, and other in which 25% of the population in Argentina is infected and 10%. So this is fixed, right? So the idea is just to provide here estimate of number of deaths based on the population of Argentina, the case fatality rate in China, and these three scenarios, right? So as you see, most of the death is expected to occur in all the people, right? In any scenario. And the important thing here is that if we avoid, let's say, or we apply interventions that keep the infection level at 10%, we can avoid a significant number of deaths compared with these other two scenarios, right? So let me show you this part here. Again, we are putting the similar information, but in graph. But you see that we are able to change here and interact with the tool and change the level of infection. So in this case, the infection is at 10%, but I can change that to, let's say, 25 or 24 or 30%, okay? And this is going to impact this tool, I mean, this part of the tool here. Again, the data that we are presenting here is the population that is fixed by age. We have the case fatality rate from China that is selected here. And this is the estimate of number of deaths using population, case fatality rate, and this level of infection in the population. So we are able to play with the tool and not only have these three fixed scenarios, but to change the level of infection and the case fatality rate to get the expected number of deaths by age. So we have highlighted here in red the population in the age group over 6 years old, just because we notice that the impact of COVID-19 in older people. So this is the tool, and we have other feature here. We have a kind of interactive table that this is in case that we are interested in download the expected number of deaths or projected number of deaths for further analysis. Okay, so again, we can select the case fatality rates, and we are able to change also the level of infection. The tool is complemented with some technical notes here, explaining, providing, again, data sources, measures, methods, and some references, and also a section that describes the tool, right? So let me go. I mentioned that this tool is for, again, global, regional, and national level. And we developed a second one. After this, we developed the second one. That is this one. Let me refresh.
Ramon, sorry to interrupt, but you've got about 1 more minute, mate. I'm really sorry.
Okay, no, it's okay.
This is great.
It's okay. This is pretty much the same, but the good thing is here is that we are able to select one country and also present the estimate not only at national level, but at subnational level. Let's say that I want to present this for Distrito Federal in Brazil. So this is similar again, but allows us to go inside the country and estimate the expected number of deaths. We have other feature here in which for a selected country, we are able to present the estimated death by in this case, state in Brazil. So I encourage you to take a look at these two tools and give us feedback on that. So I appreciate again the opportunity to present this tool in this webinar. Thank you so much.
Thank you so much, Ramon. I'm sorry for rushing you.
No, it's okay.
I mean, what it might be interesting in the discussion is people who, have a background in doing demographic analysis and modeling and projections to hear what they make of this. So I think we'd welcome those insights, and whether you regard this as something which has got so many assumptions been built into it that it might have been the best we could do at the time, but it's outlived its purpose, and what wider lessons we can draw from that experience. But now what I'd love to do is to introduce from the north of Britain, where the sun is shining, Aravinda Guntupalli, who is going to talk about the demography of COVID and older people in India. So the floor is yours, Aravinda.
Can you see my screen? Can you hear me well? Okay.
Yep.
Excellent. So let me put in the sharing mode. So I'll be today talking about the impact of COVID-19 on older people in India and the policy response. So the big question when the COVID-19 pandemic started in terms of impact on LMICs is what is the specific impact on older people? The question was more important because especially when COVID-19 started in European countries, the media was fully kind of showing pictures of older people, whereas when we moved to countries like India, older people did not receive much attention. So the questions to ask is, did the pandemic further increase the invisibility of older people? Also simple questions like how many older people are impacted and what is the level of impact? So I'll quickly show the current statistics and what the situation is in India in terms of COVID second wave and generally. So the first wave of COVID continued till early 2021, but then the second wave started here. As you can see, the wave 2 is really highly impactful, both in terms of mortality and morbidity. And so far, India has confirmed 31 million COVID positive cases. Until last week, the number of people who died, according to the official report, includes 412,563 people. But when we move to case fatality ratio discussion and also discussion on sex specific mortality, the discussion seemed to be very much focused on the case fatality ratio, which seemed to be lower from official figures, which is 1.3. And one of the problems to do estimation and also to have reliability of data, which I'll talk a little bit in later slides, is that Indian Ministry doesn't provide summary level or individual level age specific information. So we don't know, for example, for each state or a district, what's the mortality like age specific. We also don't know for whole India, except for a few presentations from the Ministry of Health. We don't have that specific information. So crowdsourcing platforms like COVID-19 have compiled data from all different sources available, including ministry, district level data, and then put together a platform for various data sets. And what we have, unfortunately, is a lot of missing data, which I presented last year when we had COVID wave 1 discussion on data. Majority of the age specific data is missing, and in some states the missing data goes up to 99%. So we cannot do any reliable estimates based on that. And what's the testing capacity like, and what is the kind of age impact on it? India's testing capacity has improved a lot, and so far 421 million tests happened, and also given the size of the population as well, it was scaled up in various centers. But one thing I want to just flag in the testing capacity aspect when it comes to older people is we have to remember the number of older people that live in rural areas is higher compared to younger people. So for example, out of 103 million older people, 73.3 million lived in rural areas as per the census of India 2011. And this is the recent estimate we have. So we do not know how many older people live in India currently, except for the 2019 estimates based on the 2011 census. And so which makes it really hard to calculate standardized rates as well. And again, poor COVID testing in rural area means that also older people from rural areas are underrepresented in this data set that we have. And there was no prioritization of older people. So there were no designated queues for older people with disabilities, with any health conditions, and no guidelines were released except in state of Kerala, where home-made tests and home tests and also home vaccinations were provided for people with specific disabilities. So prioritization did not happen except in Kerala. So going to the mortality database, before we talk about COVID-19 mortality data, during COVID pandemic phase, we need to talk about pre-pandemic, what happened to the database before. India never had a strong mortality database. Even though the 1969 Birth and Death Registration Act makes it compulsory that all deaths have to be registered, majority of older people that don't get registered because people don't need a death certificate unless there is a financial transaction required. For example, if there is pension, bank account, transfer need to be happen from the deceased person to the children or other family members, or when there is some land inheritance. So especially as women do not have the bank account in later life, and also in the data that shows that education and bank holding and wealth is mostly concentrated among older men, we see again further kind of missing data for older women. And also the hospital registry data show that majority of data, 62% of hospital deaths are male deaths, showing that women at later life tend to die at home. So pre-pandemic Indian mortality data was never great, and then post-pandemic it became further complicated. As we saw the slide of Peter, that the official records, discrepancy between official records and the media records, it highlighted massive gaps. For example, in the state of Gujarat, in 7 cities, the official report showed 1,061 deaths, whereas cremation showed 8,286. Same in Bhopal, 50 official compared to 1,000 plus media estimates. And then sometimes the court had to interfere as well to ask states to revise their estimates, which happened in Bihar. In the state of Bihar, the government had to revise and they increased the death from 5,424 to 9,375. But again, none of them have age-specific data. Age is not an important factor, and we do not know much about it. Then came recently, very recently, a few weeks ago, a few data activists and RTI activists, Right for Information Act activists, came together and requested mortality data for specific districts and specific states of India. So we do have data for 7 to 8 districts, 8 states, and sometimes not for all states as well. So, but it does give some information on the excess deaths and what's happening in India. For example, in the state of Madhya Pradesh, what they showed is that the COVID first wave was not increasing mortality. It's similar to pre-COVID mortality, but then there is a sudden jump in the mortality rate during the second wave. In case of Uttar Pradesh, again, the data looks slightly unreliable in that the data trend looks, it's going downwards, where almost all states seem to be already picking up mortality by second wave. But again, they haven't released the data from May, where the peak of second wave started. So it looks like a downward trend, but excess mortality seem to be still there anyway if we look at these 2 periods. And same in the case of Bihar, we see some increase in excess mortality, and then the second wave impact is visible from here with the steep increase. And we see similar kind of data availability in Andhra Pradesh, Tamil Nadu, showing that the second wave was much more impactful. You can see almost going up to 150,000, and in case of Tamil Nadu, 90,000 deaths during the April time. And then going to other 2 South Indian states, Karnataka again shows a kind of a lower mortality in April, but compared to regular mortality, but it could be because of lockdown and accidents and other types of mortality reduction. So, and what you see here again, second wave is a steep rise going almost up to 75 to 80,000. And in case of Kerala, what you see again is impact of second wave, and then second wave seem to have very high mortality. So basically what this data show is that even though we don't have age specific information, the official estimates are grossly underreporting mortality. So then moving to COVID mortality data in India, I then looked for any kind of data that I could get hold of age specific to see where are these deaths concentrated. Are we seeing the concentration of deaths among older people? So in Kerala, normally the system, it works until December 2020, 23rd of December, Kerala published all the mortality data and everyone's name and age as well. It was officially published. So people could go and check the data compared to other kinds of sources. So a group of volunteers led by a general medicine physician checked several local newspapers and 5 news channels between the March and end of 2020. And they estimated that 4,559 deaths occurred in Kerala compared to 2,646 deaths that were reported officially. So they said that underreporting could be of various reasons in India, including COVID-related reasons, but not directly COVID, heart condition, pneumonia, or blood clots or stigma could play an important role. So what I've done is I've taken the data and tried to look at the concentration of that by age group, because we don't have much of other data sets. It's only a specific kind of data that's available for certain period. And this is the mortality distribution for different age groups. And we see that majority of deaths are concentrated 45 to 59. But what I wanted to know was not the mortality distribution fully, but is the mortality missing randomly? Is the data missing randomly, or is there some kind of non-randomness to the missing data? Because with the official estimate data, as I said, up to 90% of data in some states of missing age and sex, still analysis is being carried out using the data that's available with the assumption that data is missing at random. And I've always argued that data would not be missing at random given the evidence we have pre-pandemic. And then this table, mortality percentage by gender, highlights exactly that. So out of those 1,913 missing deaths that were not in the official reports, in case of females, so you can see that 57% almost of female deaths were concentrated 60 to 69. So majority of female older deaths were not reported, were missing. And when it comes to male mortality, it was concentrated below 60. Majority of deaths that were missing were below 50. So older female deaths are likely to be missing, even in a state like Kerala, where the transparency of system is very strong with release of names and age as well, and also literacy rates are very high. So that brings to the next aspect of vaccination. So what happened to vaccination? Was there any prioritization of older people? What was the timeline like? So India started the first vaccination on 16th of January 21, where healthcare workers and frontline workers were given vaccine. And then from the 1st of March, older people 60 plus and 45 plus with 20 listed non-communicable diseases were eligible. But soon after, from 1st of April, everyone 45 plus were eligible for COVID vaccination. And 1st of May 2021, everyone aged 18 and above were made eligible for vaccination. So what I want to just show is the data by age and how many older people were covered in the vaccination drive, and this deprioritization impact on vaccine among older people in India. So if you look at the total vaccine coverage up until 4th of July, 2021, I don't want to show you different age groups. I just want us to focus on over 60 years. 68.9 million older people in India received the first dose and 25.7 million received the second dose. So if we convert this and calculate the percentage coverage based on the estimates that there are 139 million older people in India, nearly 50%, 49.6% received the first dose and only 18.5% have received the second dose. So despite the global evidence that older people have higher risk for mortality, you can see the coverage is not really great. So was the coverage impacted by deprioritization was the question. So what you see here is the graph that shows different age groups, the total vaccination here, and then the light blue showing 18 to 44 younger adults, and about 60 is the dark blue line. So you can see here when vaccination was allowed for older people and 45 plus with NCDs, older people vaccination was picking up. But once everyone 45 plus were allowed, it's kind of started going down. And once everyone 18 plus was allowed, you can see that the number of older people coverage continues to fall off or just remain stable. So it doesn't really have any kind of prioritization. But not all India behaved in similar way. There are regional differences as well and state level differences. For example, in the state of Kerala, you can see that kind of deprioritization did not have an impact because of policies where older people vaccination was also focusing on homebound older people, people with mobility disabilities, and also in long-term care conditions. You see that even though there was a little bit of decline, it seemed continued to be slightly high and also increased again from June onwards. So you see different types of patterns in different states. For example, in Tamil Nadu, older people never had higher vaccination rate from the beginning. So it continues to be a little bit high in between, but then goes on a lower level, generally speaking. And same in case of Bihar, initially it was increasing, but then it goes down. Post younger people were allowed, you can see that younger people have increase in coverage, but older people kind of stabled off. There is no increase in proportion. And that's what you see in Uttar Pradesh as well. So what evidence did government have before making this deprioritization of older people for vaccine? And then their own data, which could be again debated and discussed, showed, for example, for the first wave of India, older people 60 plus with comorbidities had the highest case fatality rate. So despite the own evidence showing that they had the highest fatality rate, older people were not prioritized and everyone else could be eligible for vaccination from 1st of May.
And then Aravinda, by the way, sorry to interrupt, you've got 1 more minute.
Yeah, nearly done, yeah. So we also know from the evidence of Lassi as well the same, that, you know, older people comorbidity increases by age. Take any condition, you see that age is a very important factor for comorbidities and chronic conditions in India. But then despite that, the first national speech by Prime Minister Modi asked a question in terms of several voices were raised, why age groups were created for vaccination. And there were some voices on why older people were being vaccinated earlier. And then I felt like the speech could have said that older people had higher risk and they should have been prioritized rather than leaving it as open-ended question, because it is important that we prioritize people with the highest risk based on the evidence that we have. And then there were revised guidelines released that vaccination is no longer state decision. It's the allocation of vaccines will be decided by central government based on population size. And as we know from Ramon's previous presentation, it's important to know size of population by age, not just size of population. So it's important to include size of population by age, because older states like Kerala and others that are demographically advanced would not then be receiving higher number because they will have less population and also the size will be lower. So that doesn't really help. So to put from a policy perspective, Kerala is the only state that has done fantastic kind of policies in terms of releasing on a regular basis in care homes, mobility disability issues as well, and also prioritizing older people for various aspects. To conclude, the real impact of COVID-19 on older people in India will be never known because we don't even know how many older people are there, their current living arrangements, we don't have age-specific data, and also other important aspects, including access to health insurance or affordability. Thank you.
Thank you, and apologies, Aravinda. I mean, this is great stuff, and we haven't been able to do justice to the fascinating detail in your talk. Clearly, what COVID does is it brings to light many pre-existing problems in many parts of the world, including India. What I'd like to do now is to hand over to my colleague of many years, I wouldn't say quite how many years, Veronica Montes de Oca from the Autonomous University of Mexico, who is going to do a presentation about the demography of COVID in Mexico. So Veronica, the floor is yours.
Thank you very much, Peter. Please, can you announcement when I have 1 minute, please?
I will do.
Okay, thank you. Thank you for accept my our contribution in this roundtable, in this panel in the British Society of Population Studies. I stayed in Liverpool a few years ago, and it's really, really interesting Congress and conference with population. I would like to share my screen. Thank you. Okay. Oh, well, that is a presentation for the older people and COVID in Mexico. And we start with my colleagues and I, we very worry about the impact of the COVID in the populations, in different group of population, and how to build the vulnerability with the intersectionality point of view. And we have in Mexico a lot of poverty, community inequalities, and obviously the COVID impact in the socio-demography inequality impact difference in the older people and older adults and everything. And we start with some of kind of point of view in the theoretical framework. And after that, we show some data about Mexico, what is the impact of the gender, indigenous population, age distribution, and obviously the rural and urban areas. This is the point of view of because it's the intersectionality is the framework who the government and some institutions now analyze the information. And that is for us is very important because intersectionality make evidence the power relations. And the inequality in Mexico is now very, very important to show what is the discrimination or what is the position in the power social and economic relations. In this sense, we reappear, we get the community inequality because Mexico have a lot of inequalities before the COVID. And maybe we naturalize these inequalities. But now with the COVID, that is very, very important evidence because it's important accumulative disadvantage in the past in the life course of the people. In this sense, we try to analyze intersections, what are established between different groups of the older population, according with the age, with the sex, with the ethnic origin and place of residence. We suppose, obviously, the information is the observed data, is the statistic of the epidemiology in the Ministry of Health, and we help to understand the trends of this information with two surveys, very important, the National Survey of Demographic Dynamics and the National Health and Nutrition Survey, because like my colleague from India, the comorbidity is another new inequality or accumulative disadvantage for understand the impact of COVID. Just for remember, we have 1.5 million inhabitants in Mexico and United States. And obviously we have a great territory with a lot of inequalities. More or less, we have 10 millions of indigenous and Afro-Mexican population. And you know, my country is a multicultural country. We have 68 languages. And obviously these people is the traditional structured marginated, no? And that is very important. Another thing is so important in Mexico is the participation in the informal activities without formal income. And that is very, very important in our country because you know the different results about to this data. Look at this structure of age and indigenous condition, age, sex, and indigenous condition. What is the total and for the people we test positive for COVID-19? And you can see this is only the test. This is only the test, and we have obviously more presence of the male in indigenous and the total population. And when we analyze to this information about the hospitalization and intubation with the health conditions, it's not surprising to see the power of the hypertension and the diabetes for both population, indigenous and not indigenous population. And the obesity was very important, especially for the older persons. That is very interesting. But when we analyze the lethality rates by sex in the different age groups in the life, no, we see the prevalence, the high prevalence for the men in old age and adulthood. Very similar like my colleagues in India. And that is very interesting because the lethality increased more or less at the 35 years and over. But when we also the indigenous conditions, the lethality rate show that the indigenous men have more risk and for death. And that is very important, especially in younger adults, no? Yeah, and obviously the men and the men indigenous and no indigenous is very, very interesting how is very high the lethality rate in adulthood and old age. And when we saw the health conditions of this information, the governmental information, the hypertension and diabetes are very important, but diabetes is more important in adulthood, and the hypertension and smoking in old age, for example, no? Especially in the very older person. And what is the problem with that? The problem is the health vulnerabilities of the older people. And these vulnerabilities is not only the comorbidity, is the lack of access to health, is the accumulation in disease and disabilities, and the interruptions for some health service to provide sites to the care of COVID patients. So many institutions stop provide consultations and the follow-up of the treatment of disease and disabilities. And another thing very important, I can't write that in this slide, is because in Mexico, only 30% of the older person have a pension. Now the government have a new pensions for everybody to 65 and older, but it's not enough. And the older persons need to go out the households, break the lockdown, because in Mexico is voluntary, but this have a risk for the population. Look, this graph, this is the age and X structure for people who died in COVID. Is the last year, and is the people of in hospitals. And obviously we can see the importance of the gender perspective, how is the form to understand the risk in the male population and women, how is the naturalized the gender has a provide breadwinner in the households, and obviously this have a lot of implications in the households in Mexico. And when you see the infected population, we can to see how in Mexico view the risk. For example, look this infected with COVID, the population. The diabetes and obesity are very important. For example, obesity in younger adults, and another hypertension and diabetes in the younger and older people. That is very important to infected. But when you die, that is very interesting how the 60 and older and the young people, young adults, live the diet, with implications in the families, in the society, and all of that are men, obviously, because they have a gender obligations now in households, and that is very interesting how they understand, how the people understand the government information and how process the risk in the life. And that is the health conditions. This is the intersectionality of age, sex, and place of residence to the disease previously to the COVID. Because previous this pandemic, we have another silent pandemic, the diabetes, the hypertension, the obesity in the younger adults and the older persons, and that is another very important situations to need to work in the public policy. And another inequalities is the universal coverage of the social security to the health institutions, and we have to work with this deficient with the indigenous and Afro-Mexican people, no, especially in the rural localities, in the rural areas, because it's when the people is not affiliated to the health institutions. And another very important thing is not a minor point, is the deficit of the specialist physicians, especially in the internistas, los internistas. We have a very lack of specialist physicians in the health institutions of the health and medical service. And obviously we need to work to replace and form new human resource to new pandemics and the follow of that. The intersection Then for the older persons to be not affiliating health institutions is high for older persons in Mexico, especially in the 50 and 85 and over, no, because it's very important to have the universal coverage. Obviously, now with the pandemic, the government established everybody free without cost have attention in COVID. But what happened with the previous conditions of another disease? That is very important because we need to see the other conditions to health very powerful to infected in COVID. But now we think about to the other dimensions, the economic dimensions in Mexico. I talk about to the very few persons with pensions and very few persons with a formal income in the formal work in the labor market. And that's, I feel that is, we feel this is a very important condition because the inequality is produce socioeconomic vulnerability in older people and in younger adults. And that is very important because it's not only the health, the physical health, is the mental health, is the economic status, the economic resource, security, and obviously the human rights. Now we think in Mexico, we have a great problem with the human rights now because we work a lot of this point for the older people, but now we feel ageism and feel excesses of protection to the family who not take in count the autonomy and independence of the older persons. And obviously the older people need to work because don't have pensions or the pension is not enough to live and to contribute in their households. And this is some information about to the National Survey of Demographic Dynamics, who show how the people, they with self-employment, no, that is very interesting. And the indigenous and the older and the Afro-Mexican is more or less terrible in this sense. And obviously we need to take a note for this public policy in my government, in my country. Just to finish, we think the intersectionality, the inequalities accumulated in the life course, the previous conditions in the inequalities are very important to understand the impact of the COVID-19. And obviously the age, sex, ethnic conditions, previous morbidity, place of residence are forms to how these categories of the inequality show the impact of the COVID and the death. No, Goran Therbon said the existential inequality show exactly when you have a high morbidity or you have a low expectancy of life. Now, we think with the data in Mexico, we need to think to combat the pandemic, but in the similar way to reduce inequality in population. It's very important, this opportunity to see how the government, how the public policy, and how this pandemic increase the inequalities in ethnic, gender, or intergenerational perspective. Thank you very much, Peter. I hope I understand with my English, and I hope to contribute to discussion in this Congress.
Well, thank you so much, Veronica. I think that was great, and it was very interesting in its own right, but I think it also brought some new things that we can reflect on in our discussion. Firstly, what you make very clear is that the tremendous diversity of people over the age of 60 in all countries. And of course, we know that coronavirus, like all health problems, is very socially determined and interacts with inequalities and intersectionality in complex ways. And I think just bearing in mind that, we talk about older people being more at risk of dying of coronavirus, but of course, the case fatality rate for somebody aged 75 is far, far higher than the case fatality rate of somebody aged over 60. The difference between 60 and 75 is much more than the difference probably between 60 and 45. So the pandemic also, just purely in terms of its epidemiology, means we have to look at older people in a way that perhaps as demographers, we tended to group them together. And now we have to be much more specific in how we look at age, I think. What I would like to do is to invite now our final presentation, which is going to be jointly given by Elena Paterin and Fabiana Saggi, both of whom are based in Brazil. And again, this is going to be a different perspective to bring to our discussion. And it's going to be focused on long-term care facilities in a single state of Brazil, the state of Bahia in the northeast of Brazil. And it's going to be looking at what's been taking place in those facilities and how a newly formed institution has been trying to support those long-term care facilities in the wake of the pandemic. And I think often demographic data tends to exclude long-term care facilities and only focus on older people living in the community. So it's very important, I think, to include a specific presentation on that neglected group. So Elena and Fabiana, the floor is yours.
Thank you, Peter. I'm Fabiana. I'll be talking on behalf of Elena Pataro. Hi, Elena. Say hello to everyone. Yes. Let me share the lovely slide that Elena has prepared. I'm just having some technical problems here. Just a few minutes. Okay, I'll be talking about this Committee for Monitoring Long-Term Care Institutions for the Elderly at the state of Bahia in Brazil. So let me give you some figures about the population in Bahia. So 11% roughly of the population, they are old people. Bahia has 417 municipalities, and it's the 5th position in Brazil in terms of territorial extension. So why did they come out with a committee for monitoring long-term care institutions at the state of Bahia in Brazil? So why? Some news that were just circulating in newspapers in Brazil and around the world. COVID affects up to 24% of old people residents in Brazil. Half of COVID-19 deaths in Europe take place in long-term care institutions, and Italy investigates millions of senior deaths in asilos. So Brazilians who are there taking care of old people in institutions in Bahia, they took a great notion of those news, and they started this committee for monitoring long-term institutions. So what's the objective of this committee? To monitor the health actions in the long-term care institutions in order to intervene and provide guidance on the care for the elderly during the pandemic. Also, they want to articulate actions of the health and social assistance policies in order to promote interventions with coverage and capillarity in the municipalities. Let's talk a little bit about the work process developed by the committee. 24 hours monitoring what was happening in the long-term care institutions weekly. So what type of works have they developed there? Network articulation, production of technical reports, testing and results there within the institutions, technical meetings, telehealth, telemedicine, internal technical meetings, qualifying the work process. They also developed activities, engagement with the public prosecutor's office, public defender's office, with the university, national front for the strengthening of long-term care institutions, which is a national movement that was formed in Brazil also during the COVID-19 period. And they've also formulated a guide to support the implementation of COVID-19 measures and policies together with health councils. What were the challenges that they faced? Difficulty in contacting those institutions, absence of systematized and updated data registry of long-term care institutions, almost exclusive contact with municipal health management, and some difficulty with the proper long-term care institution, increase of the number of institutions in that database, and especially during the vaccination period. Let's come to the data that they have. Estimation of senior residents in 85 municipalities. They have about 212 long-term care institutions with 5,259 senior residents. And there we have reported symptomatic case, what around 79% of elder population, 79%. Confirmed seniors in those institutions, they corresponded to 31%. Early death, the rate death of people with more than 60 years old, they are around 10%. And the post-vaccination news, what were they? Asylum registers, COVID-19 outbreak, and 5 seniors death confirmed. Another outbreak with 33 hospitalized after the vaccination, and another outbreak after vaccination with 37 cases just also detected that. Ongoing challenges. So in order to have an overview of the challenge that they still have to cope with, they have interviewed managers at the institutions, and they have also mapped the social demands regarding the food supplies, material provisions, and they are mapping what are the vaccination challenges also at the states with the new admissions, people that still need to be vaccinated, and especially the frontline workers. Incorporated activities, training program for healthcare professionals working in the territory, recording online classes and producing podcasts. Some concerns that the committee has been dealing with. Long-term care facilities, they are invisible at the state of Bahia. There is an articulation of actions. It has been quite difficult to manage them in an intersectorial way. absence of effective policies to strengthen the institutions. And there are also the questions of time. Everything in life matters. So here is their email address and the internet page address, in case you want just to have a look at the brilliant work that they have been doing there. Well, we are open for questions, and Elena will be joining me to answer all the questions that you have. Thank you very much.
Well, thank you, Fabiana, and also to Elena for, again, a fascinating presentation, which really complements the other perspectives that we've been receiving. And I think it was Aravinda who said, in India, we don't really know how many older people are in the country. Well, in many low and middle income countries, we don't know how many long-term care facilities are there. In fact, we don't often even have a vague, approximate idea of how many of those facilities are out there. And as we know, in wealthy countries, the pandemic mortality was very heavily concentrated in those settings. So, you know, this is not a side issue when it comes to COVID and older people. It needs to be central to our discussion. So now what I'm going to do, before we have questions and discussion, we're very fortunate to have Athena Latondoni, who is from the British Society of Population Studies, and again, somebody I've known for more years than I would dare or care to admit, at the University of Southampton, who has got the exciting, slightly daunting task of being discussant to pull together some reflections on what we've heard so far. Athena, the floor's yours.
Thank you, Peter, and thank you for the invitation, and thank you for organizing this event. It's been absolutely brilliant, and it's not over yet. And thank you to Lucas for all of the logistical support. So I won't take a long time. I just want 5-10 minutes maximum, just to raise some comments or questions for the presentations, which I hope will be fertile ground for the discussion. Although I see in the chat there's already very good questions that are coming up. So I suppose the first presentation, Ramon, that was such an interesting and useful tool. I really enjoyed that. The question I have goes back really to the premise of creating the tool in the first place. And I wanted to ask, you can respond a bit later, about the reasons behind the choice of the three countries acting as the base, so China, Italy, and South Korea. And I suppose my question really goes back to this whole seminar. So can we trust the data? And the question for you is really, can we trust those three countries' data more than others? And you know, is that another assumption that we should be cautious about when we use the tool to create the numbers? So I'm interested in your thoughts. The second presentation, Aravinda, very nice to see you again. With Aravinda, again, we go back many years, and it feels like you're here in Southampton when I'm looking at you. But thank you for a really brilliant collection of data from different sources, which showed how challenging it is for demographers really to collect data at the right level from different regions and showing the same indicator. You made a really convincing argument about elderly women's death. And I think that's a point that came across in a couple of other presentations, the intersectionality and the importance of gender. And I wanted to ask a question, which is to you and the other speakers and the whole audience, about the balance between human behavior and social policy, by which I mean, in the case of elderly women's death, what is the balance between sort of cultural reasons and stigma that you talked about, which could prevent people from reporting deaths, versus the local government's ability to accurately measure the deaths? So where does that line lie between what humans do in a COVID situation and what is expected of the local government? It's not an easy question to answer, but I'm really interested in your thoughts using the elderly women's deaths as an example. Veronica, I really enjoyed your talk and the emphasis on intersectionality. You could have been talking about the UK context in your presentation, because so many of the concepts and the arguments you made ring true. I had a question again, similar to the previous one, which is about the really stark graph you showed with many more men being hospitalized and dying compared to women. And I suppose I had the question of whether is this showing a greater vulnerability of men towards COVID, or is it showing a higher risk of women dying at home? And again, that goes back to the intersectionality between being hospitalized, the risk of being hospitalized, and gender and reporting. So I'm interested in your thoughts. And finally, Monica, it was Fabiana actually who presented. Thank you for your presentation. I didn't have a question. I mean, I thought your presentation highlighted really important issues, as Peter was saying, in other parts of the world. Here in the UK, one of the biggest scandals was a claim by the government to create a protective ring around long-term care homes, which didn't materialize. So the idea of having an agency that monitors deaths across all long-term care homes is at the heart of policy responses, not just in Brazil, but elsewhere. So Peter, if I may, I'm going to conclude with a question for all speakers, but also for the audience, which is really going beyond country context. And my question is, what are sort of meaningful or comparable indicators that we should be using at the global level to compare the measure of the impact of the pandemic on older people? So obviously deaths and reporting of deaths is really important, but beyond that, what are some of the ways we could be comparing the impact between countries in that area? So Peter, thank you for the time. I'm going to stop there and hand back to you.
Well, thank you so much, Athena. I think those are great reflections and questions, and I think you've also thrown out quite a challenging question to the panelists and to the audience. I'm certainly not going to try and reply to that immediately. I'll give you a bit of thought. But perhaps what we should do is invite the panelists to just briefly respond to those very good questions that you've raised. And while they're doing that, I think we've got about 30 people more generally participating in the session at the moment. If anybody has a question, probably the best thing to do is just raise your hand, and then I will identify you, and it will be just like you're in the room when you've raised your hand, and then I will unmute your microphone. So perhaps starting with Ramon and that question about case fatality rate data from different parts of the world. Ramon?
Yeah.
Have you got a response to that?
Yeah, thank you for the question. So it's very interesting. We always doubt the data, right? And but it's interesting. We use the data that was available at the moment in which we decided to develop the tool. So and even most of the countries were reporting number of cases and number of deaths in general, no disaggregation by age or sex, but the first countries that published a report disaggregated by in this case fatality rate in specific cities. It was in China, in Wuhan, in China, and in Italy. So that's why we selected first those two, the data, the case fatality rate from those two peer-reviewed studies. And then later we include data from South Korea because they publish also the data. And it was what was available. So that's why we apply that to our approach, trying first to figure it out what would be the impact if in specific country, based again on the size of the population and hypothetical scenario of infection level in the population, and applying the case fatality rate from those studies, we are able to more or less figure it out what is the number of expected death by age in those countries. So again, we recognize the lack of data and the need for provide additional information for planners, for policymakers. So that is the reason. Thanks.
Can I just add a rider on that as well? I mean, clearly this was something we put together very early on in the pandemic. So we weren't exactly spoiled for choice in terms of countries we could incorporate into our model. And this was something that Ramon and people did in weekends and evenings. And we haven't had time to look at more updated data on case fatality, which was probably going to be a lot more reliable because we now have much more robust testing and therefore reporting of cases from which we can derive the fatality rates. You know, if we had, 48 hours in every day, we might consider revamping and renewing this this calculator. We might also want to add data about male and female sex because we know that that has an important effect on this. And of course, we also have to consider the effect of vaccination in countries as well. So there are various things we could do, but I think in a way we feel the situation has now moved on, and what was a useful thing to do at the time perhaps isn't quite as useful as it was. But I'm just going to take a moment and abuse my position here, because this I just quickly did. This is looking at our subnational data for Kerala, and we were talking a lot about Kerala. Aravinda was talking a lot about Kerala. Ooh, it's gone back.
Oh, you need to select again the.
Yeah, I think. Oh dear, bear with me. Okay, well I'll do this as I'm talking to you. I think Aravinda's presentation and Ramon's presentation I really like, because they're trying to approach the same problem from opposite sides. So in our case, we're using data that are out there at the very high level, and just trying to then draw some assumptions from those data. And of course, those assumptions are very flawed. In the case of Aravinda, she's going out there trying to get the data which have been produced, are very fragmented, problematic data from different sources in India, and is then trying to put those together in a very messy kind of jigsaw to come up with some kind of view of what's going on in the country. So here, I mean, she was talking about Kerala. Here we've got a 10% infection rate scenario for Kerala, which was predicting these sorts of numbers of deaths that you can see here. So potentially 11,500 deaths for people aged in their 60s, 14,000 in their 70s, and 9,000 in 80 above. Now these are made up numbers, but are they any more or less reliable than maybe in the state of Kerala, the data that you can get hold of are a little better? But do we feel that both of these are essentially rather quixotic enterprises where we're simply trying to do something, but the results are just as unreliable, whether you go down out into the field and simply try and gather the information you can, or if you do something like this? And in a way, that's a question I'd like to throw back to Aravinda and to Ramon, because these are kind of the two different ways we can look at this kind of problem. So, sorry, I'll stop screen sharing and I'll stop abusing my chair to talk too much. And I'll invite Aravinda maybe now to respond to Athena's excellent question. And she may also want to reflect on what I was just saying as well.
Thanks, Peter. Thanks, Athena, for the question. It's a very complex question in terms of, behavior versus social policy, because stigma is one of the aspects, and economic issues also other aspect, where out-of-pocket payments, especially for COVID, was so expensive that there might have been further deprioritization of older women for hospitalization, as insurance coverage initially did not cover COVID condition in many states. So poorer older people might have had to go to public health system, but they didn't have complex kind of health provision. And also something I've noticed, every time somebody ended up in hospital because of COVID, like my father, I asked, how many women are there around you in the wards? And my father said there was only one woman, and she found it really difficult to be there in this male ward. And then within 5 minutes, she decided to leave. She said, I don't care, I want to go home. And then I was talking to my father and I could hear something happening in the background where nurses were negotiating, loud voices. And then I was like, what's going on? And my father said, somebody came, she doesn't want to be here. And part of me wondered, is it because everyone there was a male member, and for all the female member to be surrounded by unknown men is also some kind of, culturally inappropriate or uncomfortable. So it just opened up so many questions from economic perspective, stigma perspective, and also discrimination perspective, that there could be so many factors playing up, causing this numbers to show. And Kerala is a highly emancipated state with very low gaps in many indicators, and actually women and men are at par in terms of literacy rates and all, and still we see that older women had the highest proportion of missing data compared to. So something is really happening there. Either the values are less taken seriously, or maybe they are not taken seriously in the way, or maybe everyone is a bit more culturally focusing on female deaths compared to male deaths, or people are busy thinking about property sharing once a male member dies compared to a female member. So lots of things to think about. And Peter, coming to your question, yes, it's really a hard question, because do we provide no data at all to governments to critically reflect on, or do we provide some data with some estimates and then keep polishing the estimates that we have? So in case of India, somebody was recently saying that I don't really like that there are so many data activists suddenly emerging and providing all this data rather than demographers or epidemiologists. And I say, they are doing the job some of us must be doing, having the Right to Information Act, get the data, pushing. But we are really lost in the big politics at the moment, which party you support, which party I support, versus kind of discussions, which media channel I support versus somebody else's support, rather than the big picture of what's happening to population, what's happening to people. So unfortunately, because of these piece colliding, people versus politics, I think, and politics taking predominance over people. So I feel like the data discussion is going back. So I think we have to start with whatever we can start with, where we can show that these are the inequalities, these are the caveats, and we'll try improving it where we can. In case of Kerala, I was really lucky that I was able to find the data, individual level mortality, where I could do a bit of estimates. I'm still waiting to get other forms of data and contacting multiple people, multiple sources, and every day is a challenge to get any good, reliable data.
Can I just add a rider there? Do you think that perhaps, for example, in the tool I just showed you, for some of the other states in India where the data are so awful and largely missing, that the sort of thing that Ramon did might have some validity, at least, let's say, as an advocacy tool, to say, you may be surprised to see what proportion of deaths will be among older people, and the total numbers of deaths that could potentially occur if you do nothing.
Yeah.
Do you think it has some value there?
It has some value. And I was actually thinking that you could actually look at the Kerala mortality data and also infection rate up until 23rd of December, and then feed into it and see what mortality you get. And then we can compare it to the data. And then that will say how reliable it is, because this data that the volunteers have collected seem to be almost complete. So I think if we take that as a base where you use your tool and then forget about what Kerala data is showing, but take the infection rate and do the estimates and then see how much of gap is there, how much of correlation exists between those, and that could be a good starting point to move to other states as well.
Well, I'll put you in contact with Ramon, and maybe the two of you can do something, because that would be a very influential paper, I think, in India. Is there anything else you want to add to Athena's comments?
Yeah, Athena asked a good question in terms of the final question to everyone on what's the indicator we can use to measure other than mortality and morbidity. And this is where I also, when in the last slide, I said, we don't know anything about what's happening with older people. In India, for example, I always said that before, and also applied for funding saying that we don't have any data on living arrangements of older people because Census of India doesn't provide. And it still stands the same. Many reviewers thought, oh, it's such a boring topic. Yes, it might be very old fashioned for the UK, but many LMIC countries don't even have information on how they are coping during COVID, how they're even getting groceries, how they're getting their medical kind of devices or any kind of pharmaceutical needs that they have. It's all just completely pushed into the dark hole and no one really cares about it. And it's up to families and, you know, people who have connections or people who can use apps to contact people who are doing such social services, but the only ones who were able to get support for their family members. Others were completely left alone in villages where it just went and swept thousands of people. And I was giving a seminar for World Population Day last week, and one of the students attending said he lost 4 older people in his family during the second wave of COVID. None of them could have access to any, including his own close family member, and 3 distant relatives. So it just is such a kind, the way it came was so sudden that in the first wave, people could plan. If the neighbors had COVID, you would get cautious. But the second wave was that by the time you knew you had it, your neighbor had it, you had it. So you had no time to prepare. Everyone had it around the same time. And that made it really complicated to get hospital beds and also the money you have to spend, because I know people who had to spend £1,000 per day to more. I'm not telling how much I spent for my father because it's being recorded, but I can say that I know people who spend £50,000 also for their family members. So imagine if multiple people get sick at the same time, how do you cope with it? And then once you spend all your savings, then the black fungus came, mucormycosis started attacking people with comorbidities. So which means older people had multiple morbidities. So when they thought they got cured from COVID, they come home and then within few days they have mucormycosis infection, and that is it. And then that's the second type of infection. And I know lots of people 60 plus who have died after being discharged from hospital with COVID, but then came home, mucormycosis, and then family by that point also exhausted resources, but then they kept supporting. The injections were not available, and you had to spend horrendous amount of money to get the antifungal infections, which would be normally quite cheap. So it's really tricky on impact of older people, because I feel like people were impacted on multiple levels, economic domains, mental health, so many challenges, and it impacted, we can't say, it has impacted older people much more, but we can't say precisely what's the impact because there is no data and there is no debate on that on older people at all. The media exclusively focused on deaths, and in the first wave on migrant workers who lost jobs and became unemployed on the same day of lockdown, and they were walking hundreds of miles to reach home, and that's the focus of media so far. Older people was never an important point in Indian media. So the impact is multi-level, but we would never know.
Thank you, Aravinda. And now I'm going to give Veronica an opportunity to respond to Athena's question. And I really liked Athena's question because in a way it goes back to one of the things I said at the very start of the session, that you can present data in different ways and draw very different conclusions from it. So you can present data on how many men and women have been hospitalized because of coronavirus in Mexico or India or wherever it might be. And what does that tell you? Does that tell you about the severity of symptoms being experienced by men and women being different? Or, as Aravinda was suggesting, that partly it will also reflect a bias against women in terms of being admitted to hospital. So in the case of Mexico, Veronica, can you respond to that specific question? And also, I think perhaps talk a little bit more about what's been going on with vaccination, because I think clearly a key thing that we're all now starting to look at, as well as mortality, is vaccine coverage. And it would be interesting to know what's been going on in Mexico with that. Veronica.
Okay, thank you, Peter. Yes, thank you, Athena, because I love the intersectionality and gender perspective. And now we saw in the government message for the COVID, didn't say anything about the difference understanding the information for the gender roles, no? And I suppose the men, the perception of risk is lower than the women, for example, no? And obviously the sexual distribution of the task in domestic and family obviously is now with the pandemic reinforce the traditional roles, no? And obviously the women, and that is very important, maybe don't have infected in COVID, but live violence. And that is very, very important because Mexico have 11 deaths of women every day. Don't infected in COVID, but infected in another patriarchally forms to live in Mexico. And that is very important because we have a different levels of the inequality. The gender is the first, the socioeconomic is the second, no, the class, social class, obviously the ethnic, but the social class is very difficult with the information in the epidemiological information. No, it's very difficult because we have ethnic condition, we have morbidity, we have age, we have sex and place of residence. But I feel that is really important to see the difference in part in the subgroups of population, because the public policy need to do and say something about to the new masculinities. And what is the impact of this for the women in-house, no? And obviously, Peter, I have more questions to this descriptive analysis. We need to investigate about what is the men perception, what is the women task now, and obviously we need to understand that the government in Mexico have a feminist point of view and the gender perspective is only for the women. And that is very, very important, of course. I never think in other things, but the men need to change and to new masculinities, because in Mexico we have a very traditional role to breadwinner, but with violence, but we have a lot of evidence in different parts of the world. The men don't care the body, the health, no, and have addictions and have another forms to prove the masculinity with another man, with a society. And that is very, very good forms to research, no, with the data, because we have that in Mexico, but we need to think the different form to focus with different groups and to change the lethality and to change the risk and the chance to die in hospital. Why hospital? Because the men waiting home, and when go to the hospital is so late. It's so late. And that is very, very interesting, because we hear in different cases near to the students, near my colleagues, the men waiting home to give up the COVID, and when go to the hospital is so late, and that in this, no? And we have a lot of hospitals now with COVID especially, but the people don't understand the time in this disease is very important. My uncle, my aunt died with the COVID because they don't say anything. Don't say anything because they wait, maybe it's a flu, maybe it's another thing. No, and when you wait, you die. And that is very, because it's differently understand. In the indigenous people, I have students who family that and in the Mixteca, in Oaxaca, and it's the same. The indigenous people don't understand how the COVID act in the body. How they didn't understand because they speak another language. And obviously to translate that information, but the people don't understand because it's new, it's a new disease. And for example, I suppose, Aravinda, the religion in India is very important too. It's another dimension, because in Mexico have another dimension between Testigos de Jehová and Catholics or Christian are different. The social networks and the information and the recommendations in the source, in different sources, here is very important. Here is very important. I suppose in the India is the same. And I feel if we want to be more efficient to recommendations and the public policy, we need to complex the understanding impact of COVID. And obviously, for us, it's very important to link with the economic status. But this information is not in the data of epidemiology, but it's very, very important. And sorry, I forget your question, Peter.
No, I think you've done a brilliant job. And I think something that comes very strongly out of this discussion is what Richard Horton, the editor of Lancet, has been trying to argue, which is we should stop using the word pandemic to describe what's going on, and we should talk about, and I'll put the word in the chat, a syndemic of coronavirus, which is something which is embedded in a set of systems, national systems and global systems of inequality and power relations. And as I said before, it seems that every country's failings in terms of institutional and political weaknesses and social disparities and cleavages have all been brought to the fore by this pandemic. It's shone a very brutal light on those issues, be they about gender relations, be they about political fecklessness, whatever it might be. But what I'd like to do is now hand the floor to Fabiana and Elena. And really, I've got a particular question for you, and sorry to put you on the spot here, but from what I understand, the number of COVID deaths in long-term care facilities in Brazil, as far as the data tell us, has been much lower than we would have seen in the UK or in the USA. It's been surprisingly low mortality from COVID in care homes in Brazil. And we saw that image in your presentation before of a room with lots of beds in. This isn't a facility where older people can self-isolate. These are not always very well-resourced facilities. So is this a statistic we can trust? And we're not talking about just Bahia, where we have this wonderful intersectoral commission that was doing lots of great things to try and identify and support these long-term care facilities. But we're talking about the whole of Brazil. So is this a number we can trust or not?
Okay, I'll first ask Helena em português, if you don't mind, yeah? Helena, o Peter está falando que a taxa de mortalidade no Brasil, nas instituições de longa permanência, é bem mais baixa que nos outros países. E ele está se perguntando, a gente pode confiar nos números?
Então, aqui no Brasil, aqui no estado da Bahia, nós conseguimos a garantia da testagem dos idosos que residem nas instituições de longa permanência, mas a gente entende que são dados frágeis. Mas ainda assim, nós temos um acompanhamento de perto dos idosos que moram nas instituições e nós conseguimos garantir a testagem desde o primeiro momento.
They have been tested in a close way, the old people that are living in the institutions, but even though they understand that data can be fragile. Yeah.
Yes, I mean, it's an interesting question. I mean, it would seem, and I've asked this to a lot of people in Brazil, that it is a number that is roughly trustworthy. And again, we're floating through this uncertainty with data, as we've seen with India. And so when you find something in a country like Brazil, which surprises you, you know, you have to ask both questions, don't you? Is the number true? Or if it is true, why is it true?
Maybe, Peter, also because they acted earlier than the Europe and other countries, because they saw things happening outside Brazil and they took an early action. This might explain also a little bit.
And I suspect another thing that we did in the UK that you didn't do in Brazil was we emptied our hospitals of older people in the early part of the pandemic to make space for admissions, and we forced those older people into long-term care facilities. And many of those older people were in fact already infected with coronavirus. They became infected in hospital. So we transferred the pandemic from the hospitals to the care homes. I don't think that happened to the same level in countries like Brazil. And of course, once infection got into the care homes, it was out of control. But it's one of those interesting ones, isn't it, where sometimes you see a number and these days you just don't know whether to trust the number or to try and explain it, or how far can you trust it? You know, there's a real crisis of confidence in data at the moment, isn't there, that demographers are struggling with. And yes, I mean, I would just also like to raise the question of in Bahia, had this intersectoral commission not come together, would there have been any reliable data about what was going on in these 100 or so care homes in the state?
Quando a comissão foi formada, não havia nenhum dado assim confiável? Foi vocês que levantaram dados?
O Brasil, ele conta com um cadastro nacional das instituições de longa permanência. Esse cadastro estava desatualizado. Então, nós fizemos o levantamento aqui no estado, por região de saúde, onde nós fizemos todo o levantamento junto aos municípios aqui do estado. Uma coisa, Fabiana, que é importante falar, que o perfil do idoso que reside nas instituições aqui no Brasil e na Bahia é de idosos frágeis do ponto de vista social. Então, é uma fragilidade clínica, mas uma fragilidade mais social, uma vulnerabilidade mais social do que clínica. E, além de tudo, nós criamos protocolos de contingenciamento para mitigar os impactos da pandemia nessas instituições.
Não. She called the attention for the fact that the old people living in those institutions, they come from families with poor income. So they are social vulnerable, and they build some clinical measures to make sure that the pandemic wouldn't spread just in a very quick way. Also, Brazilian database in terms of the long-term institutions, it's very fragile and incomplete. And what they did in Bahia was they made a search looking for new institutions that were invisible, and they just somehow completed this database, and they're still doing this search and completing this database that they have.
So it's bottom-up demography, isn't it? Just like you might need to count the numbers of people being buried. You know, it's what do you do when the official data are so rubbish and so limited? Perhaps the only thing you can do is at the level of a community, go out and do your own survey.
O que você está fazendo, ele está falando, é demografia de baixo para cima. Você vai para a comunidade e faz o seu próprio survey. Como é que você fez isso? Como que você...
Nós temos uma equipe técnica da saúde e da assistência social, além da universidade, nos apoiando nesse processo. E o mais importante foi o contato com essas instituições de maneira parceira e não fiscalizatória. Então, isso aproximou as instituições para que pudessem nos dizer informações sobre a vivência delas nesse processo da pandemia. Então, mesmo sendo uma instância do Estado, nós estávamos num lugar de parceria e de apoio a estas instituições. Por isso que conseguimos construir esse mapa de instituições aqui no Estado.
Yeah, state societies and universities, researchers, they were all engaged doing this search. Yeah, they were not giving penalties to institutions that were not registered or working in a formal way. So
a
that's
comparison I make sometimes is, for example, in the HIV pandemic in places in Southeast Asia, public health authorities had to work with brothels to target areas of high rates of infection. And of course, many of those brothels were illegal, unethical, etc., etc. But sometimes you have to hold your nose and you have to do what it takes. And I think in this case as well, there's just a real need not to necessarily judge the quality of care or whether there may be some forms of elder abuse taking place, but simply to get in there and try and establish some engagement with those care homes. Otherwise, we don't even know they exist. Have we got any questions from the floor? We seem to have a very satisfied audience who don't seem to be asking any further questions. So have any of our panelists, or Athena, has anybody got anything that they feel would be useful to throw into our discussion at this point, or otherwise I can just go to my final couple of slides, my thank yous, and so on and so forth. No. Okay, well, and our attendees number is dropping quite rapidly, so I better get in there fast before it's just me on the Zoom. So, well, thank you, everybody. Firstly, I just want to emphasize for people who haven't engaged with the global platform that we do have a large element which is about data and demography, and we're always interested in working with people who may have interesting things to contribute to our limited knowledge in terms of what's going on in terms of older people. And if you do want to engage with us, if you want to contribute a blog, if you've got any questions or anything at all, really, you can send an email to this address. Oh, sorry. And one last thing as well is our next webinar is now going to be on the 10th of September and is looking at COVID and intergenerational justice. So a very different theme. And this is going to be organized jointly with UNICEF and the Lancet COVID Commission. So that should be an interesting event. So without further ado, I would like to very much thank my friend and colleague Lucas for facilitating this and doing all the important things behind the scenes. I would like to thank University of East Anglia, which funds this to a limited extent, which I'm very grateful for. And thank you very much to all our excellent panelists and to Athena, our discussant, and to our participants. And I hope to see you all sane and well and enjoying life sooner rather than later. Okay, goodbye.
Goodbye.